Well, good morning, folks. Good to have everybody online here again this morning. And pleased to reintroduce Cara Poland, who is going to give us part two of her substance use disorder presentation. She'll include a couple of comments in follow-up from last week that y'all had offered to me along the way. So we'll just dive right into it, Cara, and thanks again for joining us this morning.
We'll go ahead and get started. And their dad is here, but two kids going in two different directions can be hard. All right, thank you for having me back. For those of you who weren't here last week, I'm Cara Poland. I'm a board certified and fellowship trained addiction medicine specialist out of Grand Rapids, Michigan, and I'm with the College of Human Medicine. And we very excitingly now have an addiction medicine fellowship. We'll be welcoming our first fellow in July at Trinity Health in Grand Rapids. So excited at opportunities to maybe connect more amongst the fellowships, because as we all know, misery loves company. So why wouldn't we want to get our fellows together so they can talk about us all behind their backs? That sounds refreshing. Today, last time we talked a little bit about the disease of addiction and a bit about how we treat it. Today we're going to talk about addiction in the community. I like to talk about this topic with you all because you usually have some really good insight. I usually learn something learn something along the way as well, because you all definitely have a great perspective on how people and their illnesses interact with their communities and their families in a way that I think many other physicians don't. So again, I welcome questions. The chat sometimes gets a little hard for me to always follow because as people join, and they log in, I get distracted by that. So if I miss a question that's in the chat and somebody else sees it, please just interrupt me. Feel free to also generally interrupt me with a verbal question if that's easier. So with that, we'll go ahead and get started. So this is obviously a Hemingway quote. And I like to tell people that people with a substance use disorder who enter recovery or remission are better people than they would have been if they didn't have the substance use disorder in the first place. I am in no way advocating for the development of substance use disorders, but as I'm sure many of you have seen in your patients, having a severe persistent illness can change people in a positive way. And then in my world, when they come out on the other side of their illness, oftentimes they have really remarkable insight into humanity, into people, and are just really kind and compassionate souls. So I'm going to go through a series of really famous studies in the addiction world done by a researcher out of Vancouver, British Columbia, named Bruce Alexander. He did these what are colloquially referred to as the Rat Park studies. And if you are interested, there's like a cartoon strip. We'll see a couple images from it, which goes through his whole series of studies. It's only about 60 cartoon squares, so it's not too long to go through if you're interested in a little bit more detail. But he started his experiments in the 1980s, and what he did was he put a rat alone in a cage, and he gave the rat the option between unadulterated water and water that had been adulterated with cocaine. Of course, at that time in our history, cocaine was kind of the big substance of misuse, although heroin was definitely also a player in that time period. And many of these studies, after being done with one substance of misuse, were then repeated. So it has been done with both cocaine and morphine. But they did the water bottle adulterated with drugs and the water bottle plain. And the rats used the drug water until they overdosed. And that was one of the contributing factors to kind of the rationale for the war on drugs. I don't want to misconstrue the war on drugs. It was, in fact, intended to be oppressive against the BIPOC population, as well as against the hippies. And there, as things from the Nixon administration of documents have been made public, it is very clear that that was the intent of the war on drugs. But these studies were used as a rationale for the war on drugs. And so what they learned from that, what they took from that was somebody who uses cocaine, somebody who tries cocaine is going to use cocaine until they die. And what we know is that it's a little bit more complicated than that, right? And so one of the reasons that we use rats as an analog for humans is that rats are social creatures, as humans are. And so what the next series of studies that they did was they created Rat Park, hence the name of the set of studies. And so Rat Park had all the things that a rat could want. It had food, it had great food, it had beautiful houses, it was composed of nuclear family units and extended family units, and there was lots of social support and lots of toys to play with and things to activate their brains, both things that they had to do cooperatively and things for more individualistic rats. And they gave the rats the choice between plain water, unadulterated water, and adulterated water. And while many rats tried the adulterated water because they didn't know which one was which at first, the vast majority of them preferred to use the unadulterated water. But there were some rats that still used the adulterated water. A small portion of them, but some rats developed what we would maybe consider the rat model of a substance use disorder. We don't really have a substance use disorder as defined in humans. In a rat population, we really look at that use amount in the rat population. But there was some evidence from these studies that those rats kind of were skittish, did not interact in healthy ways with the other rats. So some of their behaviors changed as well. So the rats alone drank the drugged water. The rats in the park tried it and did not continue to use it. So meanwhile, we had kind of the Vietnam War. We had the Vietnam War going on kind of a little bit before that, but we're fudging the dates a little bit. Shh, don't tell. And so during the Vietnam War, about 20% of soldiers used heroin while on duty. So there was this huge concern for reintegration given their clear addiction. And I mentioned last week that that the two largest treatment for the children and husband left for school and work. So we are in the clear for interruptions. Thank you for your patience with my family. The two largest treatment facilities in the United States for substance use disorder are the carceral system and the VA. So this is, oh, maybe I lied. This is why the VA is such a huge contributor to just one second. One child is still here. We'll see what happens. All right. So the VA and the carceral system are the two largest treatment providers of substance use disorder in the United States, and this is why the VA is one of the largest treatment centers for substance use disorder in the United States. We were concerned that when these soldiers returned from the Vietnam War, that they would have that we would have this huge epidemic of substance use. So the VA built up a workforce and built up some strategies to address that. So what happened from there is that the soldiers started returning to the United States, and about 95% of them discontinued use after returning home. They did not develop that substance use disorder. They returned to families and loved ones in a community. They returned to an environment where they weren't fearing literally for their life, didn't know when they might be ambushed, didn't know when they might be harmed, didn't know when they might lose their life. And so that change from a state of isolation and fear into community and hopefully kindness and compassion and caring family members made a difference. And so what does this mean in terms of some of these studies, and what does this mean for our community? So meanwhile, back in Rat Park, they decided to kind of um, put rats alone in a cage for 57 days, which is about the amount of time that it takes a rat to become to develop a substance use disorder uh, in kind of our rat model of addiction. And then they place them back in Rat Park. And like their human counterparts, they went through withdrawal, but ended up, many of them, reducing their use and avoiding morphine. Now, like the soldiers, there were still 5% of the soldiers that did develop a substance use disorder that was not resolved when they got back into community. The consumption in Rat Park rose above what it had been when it was rats born in Rat Park who were offered both types of water, but it was still much less than the isolated rats. So real recovery happened in that rat population. And so the human translation, I like to say, is that people who are kind of prescribed those short-term monitored opioids don't necessarily always develop a substance use disorder. And so when we look at your population and we look at people that have pain in palliative care, certainly if somebody's life expectancy is under 6 months, I am not going to worry about um, I am not going to worry about their substance use disorder. I'm going to treat their pain. I'm going to be mindful that that needs to be a very clear conversation with the patient. I'm going to be kind and compassionate in that conversation. I'm going to listen for what they're comfortable with. I might put in some additional safety mechanisms, particularly because we know your patients don't live in isolation. At least we hope they don't. And so those family members, those friends that are supporting them also may need are at higher risk of a substance use disorder because there is a genetic component to substance use. So making sure that there are appropriate safeguards for the whole family is something that I would consider. But we certainly, would not want to withhold care because somebody has a past history of a substance use disorder. For somebody who has an active history of substance use, particularly with opioids, again, it's going to be about having that conversation and determining what is going to be best for that unit, and not necessarily just looking at and not looking just at the fact that they have illicit substance use, right? So we don't want to not prescribe for them. And I think you can clearly document your reasons for prescribing, the safety processes you've put in place. And then if somebody uses fentanyl on top of that, you document that you've had those conversations with them. I actually just graduated from the Board of Medicine. And I can tell you that if you document the risk benefit and that, and the safety processes you put in place, and then you would be fine from a medical legal, from like a board sanction standpoint, at least. And so, most of the kind of unique challenges of substance use disorders when combining with palliative care really come down to having those kind, caring conversations, right? Finding out what the patient is comfortable with, looking at alternatives to opioids where possible, which, we should be doing for all patients anyway, and looking at how, looking at maybe safer opioid options. Can you treat their pain with a partial agonist like buprenorphine, which can also kind of help with some of the cravings. With substance use, can you use longer acting opioids, which again, are less reinforcing to the brain, so less likely to, at least activate less the pleasure reward centers. When we use buprenorphine for substance use, we're prescribing it twice a day. When we are dispensing methadone from an OTP, we're dispensing it once a day. And so when you're using it for pain, you're usually using both of those medications more like 3 times a day, maybe even 4 times a day in the case of buprenorphine. So you are kind of, using them a little differently to get that analgesic effect. But generally speaking, leaning on those types of medications and really having those conversations that you know they have a substance use disorder or a history of a substance use disorder, and you don't want to put their recovery at risk, but at the same time, you want to make sure that they are they are as comfortable as they can be, that you're addressing their pain appropriately, and that you will work with them and not necessarily because a lot of them are used to, a lot of patients just in general are used to the healthcare system sort of telling them what to do. And in the cancer world, we're almost a little bit more guilty of that, where we just sort of tell people, this is what, like, this is the plan, this is what's going on. And oftentimes your patients are transitioning from, an area of medicine that is quite, still quite paternalistic, to one where you're trying to reframe that and being, um, almost, I would hasten to guess, potentially more person-centered than almost any area of medicine, which is phenomenal, and we should all learn from that. But patients may not be used to that in that moment. So I've been talking about isolation since before COVID. So it's not just, imposed isolation, but we live in a society and we live in a community in the United States where the individual is the person, is the unit. If what I mean by that is if we look at Europe, the family and extended family are the unit. If we look in our Latin American countries, it's a combination of the family and the community that are our that are our unit. And we look at our Asian and our Southeast Asian, it is the broader community. It is your village, it is your tribe. If we look in Africa, again, it's the community that is the unit. And one contributing factor, we think, to the addiction crisis here in the United States is that very individualistic mentality that we have. If you work hard enough, if you do enough, if you do, then you can be successful. I mean, we know that that's not actually true, right? I know that my children being born to an affluent family, having parents that both have at least a 4-year college degree. Obviously, I have a medical degree as well as a master's degree in education, so in a different topical area. I having adequate food, diet, nutrition, roof over their head, they are at an advantage. They are at a distinct advantage to children born in other zip codes, to children born to other families. And so while we say it's up to you as the individual, and while there is some validity to that, there are also a lot of sociocultural factors that impact impact how an individual grows and develops. We talked last week a little bit about the age of first use, right? And how when you and I were 12 years old, we were at a very different place mentally and emotionally than we are today, right? And for some of us, that's longer ago than others. But if you think about where you were, 10 years ago, 15 years ago, 20 years ago, and the person you are today, those are usually very different people. And we are hoping that we all have a growth mindset and have become, better humans, better contributors to society, all of those fantastic things. But the other thing to remember is that any one individual can potentially change their family tree, right? So if we have a person who if we have a person who, the example I always give is Fred Meyer. If Fred Meyer wasn't Fred Meyer and hadn't developed Meyer grocery stores, his children and grandchildren would not have the same opportunities as they did and do because their grandfather started Meyer. I do a lot of perinatal addiction work. So there's some perinatal data for a group called Nurse Family Partnership. It's not substance use only, that in Michigan, we have something called Michigan Infant Health Program, MIHP, which is an analog for those of you that are familiar, but essentially it's a visiting nursing program during pregnancy up to the first 18 months of that toddler's life as well. And what their data showed was that one of the impacts they had was that the grandchildren of women who were involved in this program, and it really looks at enrolling first-time mothers from marginalized populations and from low socioeconomic status, as well as racial and ethnic minorities. So women who were enrolled in that program had the nurses come and assist them. Actually, their grandchildren were more likely to graduate from high school. So by treating that one person, by changing that one person's story, we can have a generational impact, which I think is pretty phenomenal. While we have a culture that is very connected, while we can all do things like this via Zoom and have multiple programs involved and kind of increase that end for richer conversations, there is a difference between being on the Zoom screen and being in three-dimensional space with another person, kind of seeing them in that three-dimensional space really does change how our brains perceive that connection. And I don't know about you all, but there have been people that I've met, kind of like re-met almost in the post acute COVID era, where I am like, oh, so that's what you look like. Where I'm like, I didn't even recognize that person, even though I've met them on Zoom, repeatedly. So we do as humans have a need to bond and form connections, and you all are aware of this. So what we say in addiction is that the opposite of addiction is human connection. We've talked a lot in our history about individual recovery from addiction, and I feel that Bruce Alexander was very correct in saying we need to talk about social recovery. We need to recover as a community, as a nation. According to the WHO, internationally, illicit drug use is the #1 most stigmatized medical condition in the world, with alcohol use being #4. I'm going to pivot a little bit from this topic to speak a little bit about the Michigan Opioid Advisory Commission. There were a set of national settlements involving the manufacturers, distributors, and marketers of pharmaceutical opioids that's resulted in these opioid settlements. Michigan signed on to the national settlements as one of 46 states. It's a multi-billion-dollar settlement. Michigan is receiving a disproportionately large amount of the money. We are receiving $1.5 billion. These are the players that are part of the national opioid settlements. Michigan is, so there are different structures in every state. So Michigan's it was set up through Public Act 84 of 2022 to develop the Opioid Advisory Commission. And these are we are a legislative commission. So we sit in the nonpartisan legislative council. I keep saying we. I'm not sure if I failed to mention that I chair this commission. I was elected by my peers on the commission after being appointed by the former Senate Majority Leader. So we make recommendations to the legislature about funding initiatives. We report directly to what they call the Quad in Lansing, which are the two minority leaders, the Speaker of the House and the Senate Majority Leader. We develop recommendations and recommend any policy changes. The Exhibit E of the National Opioid Settlement kind of dictates what these settlement dollars can be used for. They are for opioid remediation strategies, which does include pain management, and it does include other substances. You can use it for any substance use, and you can also use it for co-occurring mental health. But what you cannot use it for is there are limitations in terms of using it to fix potholes and stuff like that. Michigan is set up in a 50-50 manner. So 50% of the money is going directly to counties, townships, and municipalities. Kent County has designated, our commissioners have designated the Kent County Opioid Committee at the Health Department as the as the folks that are planning and spending the money for Kent County, different counties are doing it differently. However, it's notable that up to 15% of the money can be used to fix potholes. There have been some concerns in some counties where they have done things like buy a new police cruiser. Some counties have bought a body scanner for their jail, and really that's not remediating opioid strategies. Some counties have included, some counties have increased naloxone access, funded harm reduction programs. I know counties up in the Michigan's Upper Peninsula are trying to work on creating some form of a crisis center for the Upper Peninsula. So I'm sure you've all read that these are sort of our guiding documents for how the lens through which the commission looks at how we might spend this money. These are kind of the Bloomberg Hopkins School of Public Health spending principles that we try to follow, and the key one being to spend money to save lives, using evidence to guide the spending. So we want to make sure that it is evidence-based practices. I would like to note that Michigan is in the bottom 10 states in terms of transparency on how they're spending the money. As the Opioid Advisory Commission, at times it's been difficult to understand where the money is going and how it is being spent. We know that it's going to the Michigan Department of Health and Human Services, but it's unclear exactly what they're spending it on. So back in October, there was a legislative hearing in the DHHS Appropriations Committee, and some additional information was released on that day, including the 1 hour prior to the start of the hearing, a website from MDHHS on the opioid settlement was made public, and post that, a spreadsheet was posted on that website that tells you which organizations received the money. And so these are the 4 buckets that the Opioid Advisory Commission has recommended as strategic priorities, but again, it's unclear if the department is actually considering any of these strategic priorities. But interestingly, when they presented their strategy, it mirrored our strategy. So hopefully that is a good sign. And I think we talked a little bit about enhancing whole person care, and how that might support treating your patients, but that is definitely a guiding principle for the Opioid Advisory Commission. We are striving to increase that public transparency within the state of Michigan. The counties, townships, and municipalities have no reporting requirement unless they are spending greater than that 15% on, potholes or unrelated to opioid remediation strategies, things not approved in that in that Exhibit E from the litigation. These are some of our next steps, or things that we're actively doing. We are convening community we have a community engagement and planning collaborative that is broken into a few different groups and has leads to help kind of take that intellectual knowledge that is in our community that may not be people on the Opioid Advisory Commission. So kind of the old adage of, I'm not smart enough to do it myself, so I'm going to surround myself with people who are smarter than me that can advise the commission, and then the commission, my fellow commissioners, and I can put that information together. So really thankful to have that community engagement that is open to the public. We also have been doing regional listening sessions. We started sort of in southeast Michigan and have made it, we're planning Saginaw, so we will be circling back around to the Grand Rapids and Kalamazoo regions. I know both the palliative care at WMed is here, but if there are other Michigan folks that are interested in making sure that they know when their regional listening session occurs, I'm happy to share that information with this group, and that those are offered both in person as well as there are Zoom options. We are very excited that Chairman Jamie Stuck, who is the chairperson for the United Tribes, our 12 sovereign nations here in Michigan, was just recently appointed. It will be his first meeting with us today. That's where I'm heading next. So we are working on making sure that that community that has been disproportionately impacted is involved and heard and receives funding. Most of the other states in our Great Lakes region, which the conglomerate of tribes in the Great Lakes region, have directly appropriated funding to the tribes. Michigan has chosen not to at this point. So we're really trying to elevate the tribal voices there. And part of the reason we started the listening sessions in Detroit, Flint, and Saginaw regions is because of the disproportionate impact on our BIPOC populations. And we want to make sure that we elevate those concerns as well. And then we have quarterly progress reports. Our annual report will be coming out later this month. There is a website, if you Google search Michigan Opioid Advisory Commission, you can find all of our materials are publicly available. Let me see, I'm just going to do a quick time check. Okay. A lot of times people ask me about how I got into advocacy, how this kind of came to be. And I think it's really relevant for fellows because I had no idea I would be chairing the Opioid Advisory Commission when I was a fellow. I mean, I'm going to Washington, D.C. next week to speak at a House roundtable and advise Congress. Like that it still seems insane to me. I had no idea that this was going to happen. So I, like most 20 somethings, I sort of had the 20-year plan when I went to medical school and thought I knew what my career was going to look like. And, if I went back to my personal statement to get into medical school, I would be doing something very different from what I do today. But I'm very fortunate to be in the area of medicine that I am. I feel like I've found my home. And some of that was through, I tongue-in-cheek say, a calamity of errors. When I was a medical student and a resident, my mother was diagnosed with a rare kidney disorder. And her sodium potassium chloride transporter didn't work. She was diagnosed in the ICU with a potassium level of 0.9. She had respiratory failure because her diaphragm stopped working, the muscle. So she had ascending paralysis. She'd had a seizure disorder related to domestic violence for most of my life. So as she developed this weakness, we thought it was related to her seizures. And instead it was related to her potassium level. So she was discharged from the hospital. She actually had a Mediport at one point where she received 23 out of 24 hours a day direct IV potassium because her stomach had so many ulcers, she couldn't take the oral potassium. So 7 years after she was diagnosed, when I had just started my chief year of residency, she died. It was on the morning. I'm panhypopituitary, so it required some fertility assistance in order to become pregnant. And I saw my son's heartbeat for the first time on ultrasound at 11 a.m. and my mom died at 1:15 p.m. My co-chief residents had assigned me the palliative care lecture, the end of life discussion with the incoming interns that day because, quote, I understood it the best because my mother was dying. And so while I was doing the palliative care lecture for the interns, my mother did indeed die. So I was in the basement of the hospital. Cell phone service didn't work at that time. This is 2011, is practically the Stone Ages when it comes to cell phones. So when I left the lecture, my phone had a whole bunch of messages and text messages, and I pretty much didn't need to look at them to know that my mother had died. And so 7 months later, my son was born. I started my fellowship when he was 11 weeks old. Just prior to my mom dying, I had taken my younger brother to his first stint at rehab for his alcohol use disorder. And actually, he was discharged 2 days before my mom died. And then in December of my fellowship year. So, because I've jumped around a little bit, the timeline is 17 months and one day after my mother died. My brother died of a self-inflicted gunshot wound related to his depression secondary to his alcohol use disorder. I was in my fellowship. We lived in Boston, and my whole world sort of crashed at that moment. I came home, we buried my brother. 6 weeks later, my grandfather died in a car accident. And you know that I was so like, the scale of my life was such that I called my father and said, I can't do it. I can't sit in the front row of another funeral. And I didn't come to my grandfather's funeral. So if you look on the left of that picture, there's Max, my baby brother. And so after my fellowship, we decided to move back to Michigan. My husband's family has a centenary dairy, the family farmhouse. My husband was the fifth generation to be raised in. So we moved back to be closer to family and family support after all of that sort of trauma that had happened. And when I moved back here, I found out that Medicaid did not have a process for reimbursing physicians who treated people with a substance use disorder. It simply wasn't a covered benefit. So I thought to myself, well, that doesn't make sense. I thought that people were wrong. Like, I thought that the billing encoders were wrong. I was like, that can't be. Like, of course you must be able to be paid to treat, to treat alcohol use disorder. Like, there have been FDA approved medications to treat alcohol use disorder for decades at this point. And what I found out was that that was indeed true. And so I tell people that that's how I grew my purpose. Meaning came through advocacy. I started talking to people about this problem. I would talk to anyone in Medicaid that I could find. I called provider services and ended up going through a whole lot of other people. And I tell people that I would talk to anyone. Like, I'd be coming out of the YMCA with my kids after swim class, and I'd be like, did you know, to the person standing on the sidewalk, that Medicaid doesn't cover treating a person with a substance use disorder? Isn't that remarkable? People not, like, I would literally talk to everyone. And doors closed, and I would look for kind of wedges of light. At first, they opened up a billing code F11.20, which is the billing code for opioid use disorder not otherwise specified. So if you build anything that was more specific, you didn't get reimbursed, and if you build any other billing code, it didn't get reimbursed. I just kept talking about it. My daughter's name is Eleanor Roosevelt, so you get one guess as to where her name came from. And I said, I can't. I looked at my children who are never going to meet their grandmother, who are never going to meet their uncle, and they're not meeting their uncle because of a preventable cause of death, like a double preventable cause of death. Suicide is a preventable cause of death, and substance use disorders are preventable causes of death. So how are we going to build a safer community for my children? And so back in 2021, they expanded the fee-for-service reimbursement criteria to both alcohol use disorder and opioid use disorder. And it was beautiful. And it only took 7 years to change policy. 7 years of more people dying. Over the last decade, 18,000 Michiganders alone have died of opioid overdose alone. That's like saying the only deaths from hypertension we're going to count are acute MIs. We're not going to count the strokes. We're not going to count the kidney failure. We're only going to count acute MIs. So that is a gross underestimate of the toll that one diagnosis has taken on our communities. Medicaid internally referred to this policy as the Poland policy, so I think I had an impact there. But it was that perseverance, like, never give up, keep asking questions, keep at it, keep advocating for your patients, because the only way that we can make the system better is by being vocal, is by taking on some of this. And your patients and my patients often don't have the strength, the energy, the voice to advocate. In my case, their voices are often silenced and minimized. And so coming from my position of power, feel like I have an obligation. In January of this year, Medicaid expanded once more to all substance use diagnoses. So now I can treat methamphetamine use too. So I can treat stimulant use, marijuana use disorder, alcohol use disorder, opioid use disorder, which is pretty phenomenal. As crazy as that sounds, it has taken until January 1st of 2024 for Michigan's Medicaid to cover all of that. We also, in January, got expansion. So inpatient addiction consults are now a reimbursable service as well. So these are these things that get me fired up and excited. But we see that we see that there are ways that we can continue to contribute. These are sort of my big buckets of advocacy at this point, and continuing my work on I'm going to skip these slides, and continuing my work on the Opioid Advisory Commission. I know I ended this way last time, but I'm going to end the same way because that's how I end everything. I dedicate my work to my younger brother's memory. So thank you, Max, for giving me 24 extraordinary years of my life, and you will never be forgotten. But most importantly, to all the people who have lost their lives to addiction, and those that try to prevent further losses, thank you for inviting me back year after year to chat and pontificate. Hopefully, I've left some time, about 15 minutes, I think, for questions, comments, discussion. I tried to answer the questions that had come to me today. If I did not answer your question, please speak up and let me know how I can be of additional service. Both Trinity Health in West Michigan and Corewell Health. Sorry, I wanted to say Spectrum, and I was like, had like a brain freeze moment. Have general addiction clinics that can help support your patients here. You do have some addiction facilities down in Kalamazoo. The internal medicine residency program does treat substance use disorders down there as well. So there, and if there are other places and you're trying to identify or find the nearest addiction specialist, and I can be of help, please don't hesitate to reach out to me as well.
Well, thanks again, Cara. We just are so grateful for your advocacy and for your the fervor with which you approach this. It's important work, and not a lot of people are doing that. We recognize the importance and value, but sometimes feel like we don't necessarily have the skills or the background. And so part of your involvement with this lecture series is to help to embolden our fellows that they have the capacity and the resources and the opportunities.
Yeah. I have no skills when it comes to advocacy. I am sometimes like a bull in a china shop, and I'm like, well, why aren't we doing this? This is what like evidence-based medicine looks like. So it's okay to not have any skills in advocacy, and Michigan State Medical Society can help. I'm sure your whatever your state medical society, subspecialty medical society might have one or two, zealots like me that do some of this work to, as pathways in, or come hang out with me. Come with me to the Opioid Advisory Commission, see what some of this looks like. Happy to share the wealth. Happy to have fellows come, or faculty.
One of the questions that have come up, and this seems to be a recurrent theme amongst palliative docs, is, and maybe you could give just a couple of pointers or tips in how we can continue to manage pain in our palliative population in patients that have substance use disorder. One of the saddest things that I see are patients with advanced cancer and significant pain who, in their other slices of the medical pie, have been taken off all pain meds because the docs say, since you're an addict, you can't have any pain meds to manage it. Of course, we all understand that's wrong. But do you have any specific tips on how we should begin the approach to managing pain in our addicted patients?
I think the biggest thing is people want to feel like you recognize and understand where they come from, right? Whatever their background is. So so if you can, sorry. So if you can start by saying, I know I want to control your pain. I know you have this history or this current substance use disorder. And I want to do it. So I want to do it in a safe way, knowing that you have this past history. Um, would you, we will use what we call alternatives to opioids to kind of give some baseline pain management. And so I tell people, I work with pregnant people, so they can't take Motrin, right? For pain, they can take Tylenol and that's it. And I tell people all the time, like, Tylenol tends to not work so great if you take it when the pain is there. You want to take it on a bit of a schedule so that it can kind of prevent it acts almost as like a prevent the pain from coming. And if you can get people to make that kind of mental switch in their brains, that really increases the efficacy of Tylenol as long as that's tolerated by them. Um, and so kind of, finding out from them what their tolerance is, what they feel comfortable with, what they feel like they can um what they feel like would be safe for them. And then if you are going to start opioids, recognizing that they have this history, are there options? Can we start with buprenorphine, the partial agonist that has that longer half-life? Can we maybe lean into methadone that again has that longer half-life? I know, like, saying methadone to primary care is like cursing at this point. But for you guys, it's different, right? So can we lean into low dose methadone for pain that has that longer half-life, or other medications that have longer half-lives? Can we do things to make it so that it's not as they don't have to think about it as much? I really for chronic pain, I really like using the Butrans patch. Yeah, it's a buprenorphine patch. Yes, it's a patch, but unlike the fentanyl patches, it's a once a week patch. So patients they don't have to think about it. They just know that they're a Tuesday switch, right? Whereas with a fentanyl patch, they're thinking, when did I last change it? Is this a Tuesday, Thursday week, or is it a Monday, Wednesday, Friday week? Or is it a Monday, Thursday week, or a Tuesday, Friday week, right? Like, they have to keep track of when they switch their patches constantly. And so it can kind of activate that perseverative thinking that can kind of come with substance use disorders. And I also think having like a very candid conversation with them that, that these opioids will hit that pleasure reward center. We only have one pleasure reward center, and we don't have any opioids that are selective enough to only hit the pain centers and not the pleasure reward center, although the analgesia also happens in the pleasure reward center. But reminding patients that this is in what we call the reptilian brain. And just like I can't train a gecko to jump through a hoop the way I can train my dog to jump through a hoop, their brains are different. It's not an area of the brain that we really have conscious control over. And so it will light up because you have this history in a different way from somebody who doesn't have that history. So I want to work with you to make sure you feel safe and comfortable on the medication regimen that we're agreeing to try. And if at any point you don't feel safe or you don't feel comfortable, then I want to know, that day. I want to know within 24 hours that it's not working, it's not going well, so we can have that conversation and adjust it.
Thank you. Very, very helpful. Other questions
There's a question in the chat. It says, I was wondering if you could touch on uncontrolled or untreated pain's effect on substance use disorders, and perhaps even untreated pain's effect for those who have risk factors for developing a substance use disorder, or those that are in remission. So absolutely. So uncontrolled and untreated pain's effect on a substance use disorder, because those pain centers, including the mu receptors in the pleasure reward center, the mu receptor is the one that the opioids bind to, are kind of overactive. They're on overdrive trying to identify opioids. Untreated and uncontrolled pain can put people at risk for who have a history of a substance use disorder, for craving that relaxation and that release that comes with substance use for anyone, right? This is the same reason that I mean, truly one of the fastest anxiolytics that we have for acute anxiety are really high risk substances, right? Benzodiazepines and alcohol. Both of those develop substance use disorders, but they also work really well on anxiety, on a panic attack. You can give somebody a benzodiazepine and they feel better almost immediately, right? But benzodiazepines long term, there is zero evidence. I will go toe to toe with my psychiatry colleagues. There is zero evidence for benzodiazepine use in the general population for greater than 2 weeks. Obviously, your population is different again. You all like to have a different population. But there's no medically indicated reason for somebody who is otherwise healthy and has depression or anxiety rather, to be on benzodiazepines chronically. So if you have untreated pain, if you have untreated anxiety and depression, it is going to activate that pleasure reward. It's going to activate the drive from the pleasure reward center. It's going to activate that dopaminergic drive, and it is done on an unconscious level. And so that drive goes to the frontal cortex, and that person at risk for a substance use disorder, who has a history of a substance use disorder or an active substance use disorder, their frontal lobe is going to say, I know how to fix that. Pick up an opioid, pick up that alcohol, take some benzodiazepine. And that is where, that is why having that conversation so that your patient feels comfortable, that you're not going to judge them and say, why did you do that? Don't you know you have a history of a substance use disorder? What's wrong with you? That's why that preliminary conversation is so important, so that you create that safe therapeutic alliance with your patients. And you all spend a lot of time creating safe spaces and therapeutic alliance with your patients. So I know you are masters of the craft. And so I don't need to teach you or talk to you about how to do that piece of it, but having those purposeful, meaningful conversations, because again, in substance use disorder, because this is the number one most stigmatized illness in the entire world, people have been judged and stigmatized. We talked about it. Can come from, they judge and stigmatize themselves. It can come from their families. It can come from the healthcare system. It can come from the community. But that healthcare system piece really impacts how they perceive we are going to approach them. So when they walk in and they tell me that they used in between appointments, I tell them, I am so sorry. That must be so hard. Thank you so much for coming in to see me again. And people are like shocked. And I usually follow up with, well, I'm fairly certain you've probably beaten yourself up more than I could ever beat you up for using in between appointments. So let's not talk about the fact that you used is just a fact. Like let's not put any value on that, but let's talk about maybe we call it playing the tape back, how you got there. And if you've already done that, great. Let's talk about what we can do. And then from that kind of what happened, what can we implement in terms of support systems from the healthcare system to help prevent you from getting into that situation again? How can we help you strengthen that stop mechanism from your brain to prevent that from happening, or to make it so that it happens less frequently? Because it seems to me like that really sucked for you, like the aftermath of it. And people are like, yeah. And they're shocked that I didn't just punish them, tell them what to do, any of those things. But again, this is part of your craft as well. So, if you encounter somebody who uses, in between seeing you, sometimes that hey, what happened there, and how can we work together to prevent that? Because that is often in a population that is trying to get treatment for their substance use disorder, kind of ego dystonic, right? It's not what they want to be doing. And somebody who is active addiction, then we just support them the best way we can. There's no magic there, but again, we do want to treat their end of life care needs, including analgesia and appropriate opioid prescribing. We may want to do shorter prescriptions, or more safety measures in there. Blister packs with doses are an option. They have the the like automated pill dispensers that open on a timer. Have you guys seen those? Do you use those at all? I feel like that might be a palliative care tool as well. But the automated dispensers where like it opens at 8 a.m. when you're supposed to take your medication, and then the next one doesn't open until the next time you're supposed to take your medication. Those can be helpful for people who have active substance use to protect the medications because they don't have a bottle that they can trade, sell, self-administer more at a time than is prescribed. And it helps you monitor the amount that they're taking and the effect of it. Because sometimes the answer is if they're injecting fentanyl on top of what you're giving them, the answer may very well be you need to give them more to prevent that fentanyl injection. Just a little bit of a change in perspective, perhaps.
Yeah, I think that gets into the whole issue of, are there, is part of the challenge that we tend to undertreat patients with substance use disorder because we're afraid that, but when in fact, their level of tolerance, I can remember one patient in particular that had been a heroin user for a decade and now had terminal metastatic liver cancer. And he came in absolute pain, and I started him on a morphine, subcutaneous drip, and we just kept dialing it up until he was comfortable, and he was grateful. But it took a lot more than I would have anticipated. But then when you saw how much heroin he was using, and you know the conversions of that, it sort of makes sense.
Right.
So, but as far as the lock boxes, yeah, we actually use those in hospice on occasion because of the concern about. Sometimes it's not necessarily the patient issue. It's the access of those meds to family members.
Right. And also just the like, I don't know about you all, but I told you I have adrenal insufficiency, and I have an alarm that goes off on my phone for my midday pills because I will not take my 1 p.m. Cortef, and then I'll feel like crap and exhausted at 7 p.m. when it's too late to take more, or I'll remember at 4 p.m. when it's too late to take more because I'll be up till 2 o'clock in the morning if I take it at that point. And so I literally have a timer on my phone because every day, and I've had this, I've been on Cortef since I was 5 years old. So you'd think I could figure it out, but sometimes that middle of the day dose is just really hard to remember because I get busy too, right? And our patients are no different.
I get it. I share something. I have all sorts of alarms on my phones and always kept pills in my pocket. So, and what the kind of the funniest thing that my wife always gets a kick out of is when I run out of my meds on the weekend and have to call my doctor, because she can recall in past years my scolding patients on the weekend for not paying better attention. So yeah. I've learned personally just the challenges, and I've got some humility about how we self-manage meds. So, well,
yeah, with controlled medications, I always tell people only refill them if you can on 7, 14, 21, 28 day regimens so that person is always due on a Wednesday. Saves you the after hours call. Sorry. Thank you so much for having me, though.
This has been great, and I appreciate it, Cara, and folks. So we'll have this posted on the YouTube channel in just a few hours. And if you have any questions, as Cara mentioned, you can always reach out to her. If you need access to contact information, reach out to me or any of the program directors, and we'll make sure that you're connected. But thanks again, and with that, we'll say goodbye to everybody.